Good afternoon, and welcome to Grand Rounds today. Please remember to sign the attendance record and also to fill out the pre and the post test to get the CME credit that's due you. If you have any future topics or future speakers, CME committee is always interested in hearing those. Today, it's my pleasure to introduce Dr. Alan Brown. Dr. Brown attended medical school at Loyola. He stayed there to do his residency in internal medicine and subsequently his fellowship in cardiology. He's board certified in cardiology, echocardiography, and lipidology. And he's here today to update us on PCSK9 inhibitors. And please join me in welcoming Dr. Brown.
Thank you very much. It's an honor to be here. I appreciate the opportunity, and thanks for spending lunchtime with me. I appreciate it. So today I'm going to present a little bit of science, some philosophy, and then some new data on PCSK9 inhibitors. And for some reason, my slides are locked up here, so I don't know why that should be. Okay. This is sponsored by the North American Center for Continuing Medical Education, which is a CME company. It was supported by an educational grant from Amgen, Sanofi, and Regeneron. And the disclosures are listed in your handouts. Just in order to get your CME, make sure you fill out the forms as is already stated. There's CNEs and CPs also available, as well as CME credits. So you're required to provide your email address on the sign-in sheet to document your participation. Please don't forget that. Please complete the post-test evaluation in order to get your credits. And there, in the activity booklet, there should be information on how to get online credit if you'd rather do that. But you have 2 weeks to complete the online survey to get your CME credits, and that's the information I'm required to do. Please complete the brief pre-activity survey included with your slide booklet, and that will help the CME company provide better programs in the future. So today what we're going to talk about are several issues. We're going to look at the clinical evidence that supports treat to goal. As many of you know, in 2013, the ACC and American Heart Association came out with new guidelines that were focused primarily on treat risk of the patient and use the right dose of statins. That was a controversial set of guidelines, and probably you all were wondering what to do with that, as many of us were. I personally don't think it was so bad. I think using high doses of statins and just starting them on people sometimes gets them to goal better than starting with low dose and hoping they'll come back in time to up-titrate. And secondly, it was very simple, as you recall. But it did cause a lot of consternation, confusion, and anger. And we're going to talk about why there is actually data beyond randomized clinical trials that suggests that treating to a number or below a number makes sense. We'll discuss the latest clinical trial data for PCSK9 inhibitors, as well as a little bit about how they work and their safety and efficacy. And then we'll talk about appropriate candidates for the use of these drugs, and then translate that clinical trial data into how do you individualize and approach an individual patient at high risk. And I'd like to take a few minutes during the presentation to talk about familial hypercholesterolemia, which is a topic dear to my heart and one that I hope you all will know about if you don't already. So there's one of the issues with the 2013 writing group was they were given very strict instructions about how to write those guidelines. At the time, they were under the National Heart, Lung, and Blood Institute, and they were told that you have to use randomized prospective clinical trial data only, or well-done meta-analyses. You can't have any expert opinion, and there was no other data, and you could only go back 10 years. And they even had an outside consultant group pick the articles that they could use to write those guidelines. And really, they were asked 3 questions that they had to answer in the guidelines. Number 1, what was the evidence for a target for LDL cholesterol? Number 2, what was the evidence for a target for non-HDL? And number 3, what is the relative value versus harm of all the different lipid-lowering agents. And as you may know, they really couldn't come up with a target number because the data that they had to look at didn't focus on targets. It was a low dose of a statin versus a high dose of a statin. There was no trial where they adjusted the dose of a drug to get everybody to a certain number in one group, and then adjusted the dose in the treatment arm to get everybody to a lower number. So that's how you'd have to design a study to say, here's the number you should treat to, and here's the incremental benefit of getting to that number versus another number. So they basically said, we don't know what the target should be, but we know from looking at the studies that we've been allowed to review that high doses of statins do better than low doses. And so that's what the conclusion was. Now, in the meantime, a lot of new data came out. And secondly, we have a lot of observational data, which I'll review with you very briefly. The new data included studies with ezetimibe that showed significant reduction in cardiovascular events when you added ezetimibe to a statin, which previously had been unknown. And then we have now some PCSK9 antibodies, which weren't available at the time of that guideline, and we now have an outcome study, at least with one of those drugs. So we need some additional guidance, and those of us involved with the National Lipid Association and the ACC felt that there is nothing wrong with expert opinion, and most of us, when we want guidelines, we'd like to hear expert opinion. We can read the literature, but in those areas where there's not literature, we'd love to hear expert opinion. So what we'll talk about today is data that they weren't allowed to consider in the guideline document, observational data, interventional data, which they did use. Then what did genetic studies show us that might give us some ideas of future strategies for treatment, and experimental data. So all the major lipid trials and adding drug therapy or even the POSH study, which was, ileal bypass surgery, showing a reduction in lipids, showed almost a linear reduction in event rates with the more you lowered the LDL cholesterol, the LDL achieved, the more likely you were to get a reduction in events. This red line is for patients who have secondary prevention, so people who've already had an established cardiac event or procedure. And then the green line is people for primary prevention, where they haven't had a heart attack yet, but you're trying to prevent their first heart attack. And as you might guess, Brown's law number 5 is that anything that works best in the people at the highest risk. So when you look at patients who are highly likely to have another cardiovascular event because they have established disease, you're going to see more benefit, a steeper slope on the curve, than you are in people who have not yet had an event, many of which who won't. So when you look at LDL reduction with statin treatment and you look at vascular deaths avoided per 1,000, the degree of reduction in LDL, so this is the 5-year risk of a major vascular event, the degree of reduction in LDL correlates linearly with the reduction in cardiovascular events. Another piece of evidence suggesting that lower is better. And this is from the cholesterol trialist treatment group, and they looked at people with a history of vascular disease, and they were put on statin therapy based on existing major guidelines. And what you find out is that the people who have higher event rates, higher observed vascular death rates, are the ones that are currently eligible for aggressive therapy. And if their risk is less than 10%, they really have a relatively low risk of a cardiovascular event. So that 10-year risk of 10% or greater has guided us to be more aggressive with those patients in terms of eligibility for putting them on medication. And that's pretty well echoed in all the guidelines. So one thing that's been very interesting is even in genetic studies, both observational and genetic score, look at the p-value 2 to the minus 10 to the negative 10th. So a highly significant correlation between LDL cholesterol, and even in genetic cohorts where HDL is elevated genetically from birth, the p-value is not significant. So even in those patients who have elevated HDL, when you look at what really correlates with their risk of a cardiovascular event, you come back to LDL cholesterol. And maybe that's part of the reason that we've tried. HDL is a lot like psychiatry. half of what we know is correct, and nobody knows which half it is. We've tried very hard to, I mean, observationally, it looks like you're somewhat protected with an elevated HDL, but in reality, all of our efforts to raise HDL, even with drugs that virtually double it, have not translated into reduction in cardiovascular events. So either we don't know how to raise it properly, or we're barking up the wrong tree. So in terms of looking at levels of risk in cardiovascular events, patients treated with statins, among statin-treated patients, on-treatment levels of LDL and non-HDL were the best predictors of risk and the best predictors of good outcomes. ApoB was also a good predictor, but not quite as good as LDL and non-HDL. And that's why all of our previous guidelines have focused on LDL as a principal target of therapy and non-HDL as a secondary target. How many of you look at non-HDL? You do? We got one. And how many of you don't know what non-HDL is? Don't be shy. You all know what it is? It's easy, right? It's total cholesterol minus HDL. Well, it turns out that in the lipid profile, if the triglycerides are less than 200, then LDL is a wonderful predictor of risk, and that's our primary target. It's when LDL gets over 200, when triglycerides get over 200, LDL becomes much poorer at predicting risk. And you all know this. That might sound confusing, but you know it, right? If you see a diabetic with an HDL of 20 and a triglyceride at 250 and their LDL is 105, we all know that person's at a lot higher risk than we might guess if all we knew was that their LDL was 105, correct? They have a low HDL, high triglyceride. That's a metabolic syndrome patient that's going to be at very high risk. So non-HDL, or total minus HDL, is actually a much better predictor of risk in people who have high triglycerides than just looking at the LDL in that population. If the triglycerides are normal, the LDL is great. So what do? You treat the LDL to appropriate range, and if the triglycerides are still over 200, then you look at non-HDL. And what should your non-HDL be? Whatever you want your LDL to be plus 30. 30 points over your LDL. So if you have a high-risk individual, recent acute coronary syndrome, and you're shooting for an LDL of less than 70, then your non-HDL should be less than 100. The goal is 100, your non-HDL should be 130. Make sense? And how do you get there? You can increase your statin. You can drive the LDL lower. That'll make total minus HDL go down. Or you might consider adding another drug to lower triglycerides. Our approach usually is to intensify LDL lowering. So there's been a large meta-analysis of multiple trials to look at very low levels of atherogenic lipoproteins, trying to decide how low is low enough. And 30 years ago, one of my colleagues who was an endocrinologist said to me, you can't be skinny enough, you can't be rich enough, and your LDL can't be low enough. And I laughed, but 30 years later, it turns out he's probably right. So what happens is there's a lot of individual variation in how much LDL lowering you get with patients. But when you look at, if you shoot for putting people on the highest dose statin therapy who are at high risk, which is what the 2013 guidelines said, more than 40% of them won't reach an LDL less than 70. So the question is that necessary if you have somebody on high dose statin like the guidelines recommend? But it turns out that those people who had the lowest LDLs, in this case lower than 50, had their event rates reduced by more than half. They had the biggest benefit. So again, observational data suggesting that lower is better. And this is just a close look at the LDL levels achieved in patients in the statin trials and who got the biggest benefit in terms of reduction of event rates. And it turns out you can't be skinny enough, you can't be rich enough, and your LDL is low enough, which brings up the issue is there a number that's too low? Anybody think there's a number too low for LDL? Nobody? That's great. Anybody ever removed a drug because somebody's LDL was less than 25? I don't believe it. Everybody does, but it's not necessary. So as you'll see, the most recent study with PCSK9 antibodies, the FOURIER trial, had many, many patients under 25 LDL. What was the most common side effect of having an LDL less than 25? Longevity. And I'll show you some genetic data of patients who had a mutation in the gene that codes for their PCSK9. So there were 3 individuals that actually had no functioning PCSK9. So nature had done the experiment of knocking out their PCSK9 without having to give them a medication. And their LDLs throughout their life were 12, 14, and 17. And the oldest is in their 60s now, and they had absolutely no issues. So that's encouraging. It's not a 20-year study with drug therapy, but it's certainly encouraging that those patients with very low LDLs, as well as others that have different genetic disorders that cause low LDLs, seem to do okay without side effects, and they seem to have an absence of atherosclerosis. So if we look at patients that were treated achieving LDL less than 100 versus less than 70, and this is from the National Health and Nutrition Survey, administrative claims data, and EMR reviews, you can see that the highest risk patients, we still have a fair amount that, this is as a percent of all treated patients that don't achieve adequate goals. And when you do aggressively lower their LDL below 70, you see better outcomes in terms of event rates. But we still have a long way to go to get our numbers lower in these patients. And I think the way I summarize this data is, yes, lower is better. We've moved away from a target, so if I say the target is 70, we're not trying to shoot for 70, where 69 would be off and 71 would be off. But 70 is a threshold above which you would add more therapy. So what the current thinking is, and I'm summarizing because there's too many slides in this deck, what the current thinking would be that use the 2013 recommendation. So for moderate risk people, use a moderate dose statin. For high risk people, use a high dose statin. For the moderate risk people, try to get at least a 30% reduction in LDL, and for the high risk, at least a 50% reduction. However, you have the option of also looking at their numbers, and if the highest risk patients still have an LDL over 70, after you've done that, you can add additional therapy. You sort of don't care where you end up. You just want to, if you're above 70, you want to get below it. So it's not really a target. It's a threshold above which you add additional therapy. Does that make sense? Now, why do we have this semantic argument? Because it makes the people who wrote the guidelines comfortable. They're not comfortable with the term target, but they're perfectly comfortable with a threshold above which we would add additional therapy. And why can they be comfortable? Because we know if you add ezetimibe, now we can show a reduction in events on top of statins. If you add a PCSK9 antibody, at least with evolocumab, we have that data, that you can see a reduction in events. So it makes sense scientifically that being more aggressive in those people where you don't achieve the low numbers makes sense. Now, familial hypercholesterolemia, we have a much harder time achieving goals, even when we use the highest dose statins. So even in the people that we reduce LDL greater than 50% according to the recommendations, there's still roughly half of them that won't get their LDL to target. So let's pause for a minute. How many of you know what familial hypercholesterolemia is? Okay, we got one in the back. How many of you have had one in your practice? Okay. So that's why I'm here today. This is why I took a day off of work to come and talk to you. I want you to leave here and know this because it's really important. So I'm going to tell you a very brief story. I have a 64-year-old woman who came to my office and told me that she had been tried on multiple statins and got muscle aches. So her doctor had recommended she come to the lipid clinic to see if we could come up with a therapeutic option for her. And I looked at her cholesterol and it was 340 and her LDL was 260. Her HDL was normal, her triglycerides were normal. And I said to her, do you know what you have? She said, yes, I have very high cholesterol. I said, no, you likely have familial hypercholesterolemia. And the tip-off is to see an LDL over 190 with any family history of premature heart disease. So as a starting point, when you see that LDL cholesterol approaching 200, you should think about the most common inherited genetic metabolic disorder, which is familial hypercholesterolemia. It's 1 in 250 people, so you've all seen one. And there's 20 times the risk of a cardiovascular event compared to a normal individual. So what you have to know is this is a dominant inherited trait, which means if you inherit a bad gene from one parent, you get the disease. And what is the disease? Very easy to understand. It's a mutation in the gene that codes for the LDL receptor. So your LDL receptors don't work. So if you're typically a heterozygote, one parent is normal, one parent carries the bad gene, and you're unlucky enough to get that bad gene, half your LDL receptors don't work, so your cholesterol doubles. That's why your LDL is over 190. And because it occurs at birth, 20 times the death rate. So what do I need to do with this patient? Number one, I need to treat her very aggressively. Number two, I got to ask her about her kids, because it's a 50-50 chance one of her children might have gotten the gene. So she had seen 5 physicians over the years. Nobody ever told her to screen her children. And I asked her, do you have any kids? And she said, yes, I have 2 daughters in their 30s and a 28-year-old son who's an Army Ranger. And we talked about him for a little while, and I explained to her, go home, get the kids tested right away. Because we normally treat the children with FH starting at age 7 to 8 years old. We treat them with low-dose statins, 10 milligrams of atorva. I've got a 9-year-old kid with a cholesterol of 385. And on 10 of atorvastatin, his cholesterol's 160 now. So kids do very well with very low doses. But at any rate, her 2 daughters, of course, went and got their blood test right away like women do. Thank God for women. They drive healthcare. They take care of themselves. And they were normal. Her 28-year-old son told her, Mom, I'm in the Army. I've had 3 physicals. And they would have told me my cholesterol was high. And he died 2 weeks after that. And it was heartbreaking for me, more so for her mother, for his mother. And had any of the 6 physicians she had seen prior just mentioned to screen the children, he'd be alive. So my advice to you is understand this disorder. If you see somebody with an LDL over 190, examine them carefully. They frequently will have little bumps on their knuckles, the tendons over their knuckles. Feel their Achilles tendons. Many of them will get lumpy, bumpy xanthomas on their Achilles. But make sure you screen brothers, sisters, children. And if any of the brothers or sisters or children have the LDL, children, by the way, LDL over 160 is the tip off. They're not at 190. They're lower, but LDL over 160 in a child of an FH patient, they've got the disease. And it tends to go up as they get older. So you'll start the kid on low-dose statin, and as they get older, you're going to have to increase the dose. But please don't forget that if you don't remember anything else from the talk. Okay, so what are the implications for guidelines? And looking at, low to moderate intensity, this is Paul Ritger's study, and he reviewed several clinical trials. And I'm not going to belabor this, but he was trying to figure out, who's going to get the most benefit from adding on therapy in addition to statins. So this is a goofy slide to try and understand. But basically, if you look at the people who had less than a 50% reduction, they're in blue in all the trials, and this is almost 8,000 patients being observed, and they were put on statins, right, on good doses of statin. But there's a population that got absolutely no reduction on statins. Now, why? Maybe they were totally resistant, or maybe they didn't take it. But there clearly are a significant number of individuals who got no reduction, or it even went up. And then here's a group in green who got more than a 50% reduction on their statins. So based on the current guidelines, this is good, right? But what are we going to do with this group? And this group would get the greatest theoretical benefit from being on a PCSK9 antibody added on to their statin, because they're the group that actually got less than expected benefit from statins. This group that got somewhere in the 40 to 60 range, they might get theoretical benefit, and we'd have to look at cost effectiveness. But the people who got greater than 60% reduction on the statin, in other words, those quite responsive to statins, they would probably get the least theoretical benefit. So some idea of maybe how we might choose to target patients and why the current FDA recommendations say to use PCSK9 antibodies in patients that haven't achieved adequate LDL lowering despite aggressive traditional therapy. Now, I'm not going to belabor the guidelines for too long, but there's so many of them, right? We have lots of guidelines, and this is a comparison of the major guidelines. So what the guidelines for ACC and AHA said was use a statin as first-line therapy, high dose for high-risk patients, moderate dose for moderate-risk patients. Low dose was not recommended for anybody, just something to keep in mind. Alternative or add-on therapy like ezetimibe or PCSK9s, well, at that time they didn't have any outcomes data, no randomized prospective trials. So they said generally not recommended, but if you do choose to use it, you should use ones that were proven in clinical trials to reduce cardiovascular events. And since that time now we have 2 that are proven in clinical trials. The American Diabetes Association, very similar, but instead of focusing on no specific target, just the right dose of statin, they did use LDL targets. The European Society looks very similar to our old ATP3 recommendations. They recommended LDL cholesterol and then to use non-HDL or ApoB if the triglycerides are elevated. And they still were talking about adding bile acid sequestrations, cholesterol absorption inhibitors like ezetimibe, and they still said in certain cases nicotinic acid, fibrates, and omega-3 fatty acids. And the International Atherosclerosis Society, very similar to the European Society, but they moved away from LDL targets. So it's confusing, right? Yes, the more opinions they have, the less information you have. I'll give you a minute to copy this slide. There's about 5, actually, at least 5 great articles on how to do a PowerPoint presentation. This slide breaks every rule in all 5 articles. But the idea here is just to show you how many recommendations there are. What are the recommended targets or goals? I shouldn't use the word target, but thresholds. LDL, non-HDL, ApoB, and HDL. You know, and some recommendations actually still suggest raising HDL. This is the old 2012 Endocrine Society recommendations. But they all start with initial therapy of lifestyle and statin. Statin remains the primary goal of therapy. And use of adjunctive non-statin therapy, the common theme in all of these is when they do not reach their threshold. So if patients don't adequately get their LDL lowered, add therapy. Now, what did the National Lipid Association come up with? Well, as the president-elect, soon to be the president-elect of the NLA, I was there when the 2013 ACC recommendations came out, and I can tell you a bunch of people at the NLA went ballistic. That's not smart. Besides FH, if you learn anything, don't go ballistic. People don't listen to you when you're angry. That's why you have to practice before you go into a meeting how you're going to behave. And if you know that you're going to get emotional about something, you have to force yourself to think, how am I going to behave in there so I don't get emotional? Because when you do, people stop listening. That's Brown's Law number 4. But Brown's Law number 1 is that the way you influence people has absolutely nothing to do with what they think about you. It has everything to do with how they feel about themselves when they're in your presence, right? So if you tell a group of people who are writing guidelines you're a bunch of idiots and you don't know what you're doing, it's highly unlikely they're going to invite you to dinner and ask your opinion. It's common sense, but so many people don't have that common sense. So remember, take a moment to make others feel good about themselves, and you will be able to have great influence upon them. They won't know why they want you around, but they always do, because they like you, and because they feel good when you're around. And that's just a very important rule of success. And if my ex-wife had known that, we'd still be married. She was a carrier for heart disease. She didn't have it, but she gave it to everybody else. At any rate, what did the NLA recommendations say? I'm remarried to a wonderful lady, by the way. I'm growing my hair back. This looks very similar to ATP3, doesn't it? That people at low risk, you want to achieve a non-HDL at least below 130. But everybody with LDL over 160 should get started on drug therapy. And if LDL is over 190, you should be thinking about FH. Even if they have no other risk factors, you would aggressively treat them. And then the moderate risk people, 2 or more risk factors, non-HDL 160, LDL roughly 130. Et cetera. And then for the high and the very high risk, we still recommended trying to get below 70 and initiate therapy if their LDL is between 70 and 100 and try and get that number below the threshold. So what AHA said, because they didn't have the data we now have, was that non-statin therapies as compared to statins didn't provide acceptable risk reduction in vascular events, and the benefits relative to their potential for adverse effects didn't seem to outweigh the potential for negative effects. And because of AIM-HIGH and HBS2 Thrive, which were studies of adding niacin to statin, not only did they not show any benefit adding niacin on top of a statin, they actually showed negative outcomes, right? Higher diabetes, higher infections, higher bleeding. These people had to take aspirin in addition to their niacin. So what you should know is that going back to the 1970s, we have a study that compared to placebo, adding niacin did reduce cardiac events in people with established coronary disease. But when added onto a statin, we just have not been able to show that it reduces events, particularly if you're just using it to raise HDL. So most cardiologists were giving niacin on top of a statin once their LDL was low on a statin, but they still had a low HDL in order to try and raise their HDL. That was basically the group that was enrolled in AIM-HIGH. Primarily, they had isolated low HDL with triglycerides less than 200. Their HDL came up a lot on the niacin, and their LDL actually went down additionally, but they got no reduction in cardiovascular events. So that's why I've kind of abandoned niacin because of its potential for harm. Fibrates in ACCORD, which was statin alone versus statin plus fenofibrate, the overall results of the trial were negative. Adding the fenofibrate in diabetics on top of statin compared to placebo on top of statins did not reduce cardiovascular events. But there was a small subgroup who had triglycerides over 200 and HDL below 35. And that group seemed to get with a p-value of 0.056. They were very close to looking significant. So that's the only group where we really have the high triglyceride, low HDL patient who's already, despite being on statin, they still had a high non-HDL. And though this is suggestive, it was a secondary endpoint in a trial where the primary endpoint was negative. So we have to be very cautious not to take that as science. So the NLA perspective on lipid drug therapy based on their guidelines, or their recommendations, I should say, is that if the non-HDL and LDL goals are not achieved with statin therapy, when you use the guideline-based therapy, moderate to high dose, then the addition of evidence-based non-statin therapy should be considered, such as ezetimibe. You could even consider bile acid resins, which many years ago were shown to reduce cardiovascular events. And there may be isolated patients where you would want to add niacin, not to raise HDL, but to further lower LDL when nothing else works. Okay, I'm going to skip this slide. So in this year, let's just show you some diametrically opposed approaches. Well, the ACC-AHA, they were so fixated on randomized clinical trial data that they almost ignored a lot of stuff that just slaps you in the face, right? That wasn't randomized trial data. The Endocrine Society came up with recommendations, and I have no idea what data they came up with to make this recommendation, but this was all expert opinion and less data. But they said that for extreme risk, get the LDL less than 55. They may be right, but I have no idea where they came up with that number. And then they also came up with some targets for ApoB, which are similar to what we've seen in the past as recommendations, though no trial has specifically targeted ApoB. ApoB, non-HDL, and LDLP, or LDL particle number, all three are very similar. They're measures of atherogenic particles. The beauty of non-HDL is it's free and you can calculate it easily from a lipid profile. It's just total minus HDL. But some people are believers in ApoB and others in LDL particle number. They're all three similar. Let's take a moment and talk about the genetic studies. Any of you have 401k plans? So the beauty of a 401k is if you start early enough, it really grows, right? So think about what we do in clinical trials. We wait till somebody has a cardiovascular event. The horse is out of the barn, so to speak. Then we put them on traditional treatment or a statin, for example, or low dose versus high dose, and we follow them for 5 years. And we see benefit, about half the risk. But everybody talks about, well, there's still a lot of residual risk. And depending on who you're talking to, they always have an answer why. Maybe you didn't measure the Lp(a). Maybe you didn't do a LDL particle number. But in reality, some of them, their blood pressure isn't controlled. Some are pre-diabetic. They're overweight. Some of them smoke. There's a whole bunch of reasons to have residual risk. And, when you add them all together, you can explain about 90%. But what about having a benefit from birth, and does it pay off like a 401k plan? So I wanted to show you a little bit of genetic data that may stun you, and it may actually give you some ideas about how we ought to think about the next 20 years of preventative therapy when we look at a whole population. So this is a group of patients in a normal situation. These are African American patients. And we know that there's a group of them that are born with a genetic mutation in their PCSK9 so that it doesn't work very well. And they have roughly a 28% lower LDL. So this is people that have one good gene and one bad gene. It's not people, like I mentioned, who had no functioning PCSK9, but they had reduced levels of PCSK9. Their LDL only went down 28%, but it started when they were born. So that would be equal to about 10 milligrams of pravastatin, given when they were born. Look what happens over the course of their lifetime. 88% reduction in cardiovascular risk. We've never been able to show that in a 5-year clinical trial. This is the 401k plan. You're starting early. So a little bit of reduction early really paid off. There's another group worth thinking about. This is what I call genetic ezetimibe. The NPC1L1 transport protein is the protein that ezetimibe blocks to block cholesterol absorption in the gut. So here's a group of people that had mutations in that gene, so they sort of had natural ezetimibe. And it gave you just what you'd expect, a reduction in cholesterol of around 15 to 17%. So their LDL went down by only 12 points. But their overall reduction in cardiovascular events was 53% in their lifetime, but just a very minor lifelong reduction in their cholesterol. So maybe we should be thinking in the future of giving low-dose statins to people early in life, and hopefully that will pay big dividends later on. That's not in any recommendation. I'm just giving you that as food for thought based on what we see in the genetic data. So let's talk about what we've learned since the guidelines came out. This is the Improve It trial. This is people on simvastatin alone and people who had simvastatin plus ezetimibe. The reduction in LDL was about an additional 17%, which is what we know from all the previous clinical trials with ezetimibe. And that translated into a significant reduction in cardiovascular events. You'd have to treat about 50 people who had high-risk recent acute coronary syndrome or coronary artery disease. For every 50 of those, you add ezetimibe to the statin, you'll get one fewer cardiovascular event. Now, what wasn't studied is, does 10-10 equal 80? In other words, if you gave somebody 10 of atorva plus 10 of ezetimibe, which should lower LDL roughly the same amount as 80 milligrams of ezetimibe, do you get the same outcomes? That's kind of what we'd like to know, right? Because that's what we do in practice. We use lower doses of statin and add ezetimibe to keep the statin dose low. That study will never be done and has never been done. But we know that blocking cholesterol absorption does do the same thing as lowering it by other methods. And we got just what we would have expected per percent reduction in LDL, a reduction of events in this 7-year study. And in fact, it falls right along the curve with all the other clinical trials with statins, that the lower you lower cholesterol, you get a linear reduction in cardiovascular events. Now, genetically lowering it gives you a much bigger reduction in events than pharmacologically lowering it, because by this point, the patient's already got atherosclerosis, and they haven't had a whole lifetime of exposure to low LDL. So once again, starting early before people have disease may be the right approach, but we'll have to wait for long-term studies. All right, so let's talk a minute about PCSK9. So here's the surface of a liver cell and an LDL particle coming down. So the way this works is that the LDL binds to the LDL receptor on the surface of the liver and gets taken in to the liver and placed in an empty vacuole called an endosome. There's not much happening in the endosome, but there's a little bit of acid there. And in that endosome, the acid causes the receptor to separate from the LDL and go back up to the surface. And in fact, it can do this about 150 times a day. So there's constant recycling of LDL receptors. Now, what happens to the LDL? So once the receptor goes back up to the surface, the LDL is transferred from an endosome to what's called a lysosome that has lytic acids in it that break the LDL down into cholesterol. And that cholesterol is used to make bile and to make VLDL cholesterol from the liver. PCSK9, we now know, also is made in the liver cell. it's secreted into the circulation, and when it gets activated, it folds on itself into its active form. And how does PCSK9 work? This is a normal protein that's part of our body's autoregulatory process to maintain our blood cholesterol. So PCSK9 comes into the circulation and it binds to the LDL receptor in a different spot than the LDL. So now the LDL particle comes down and attaches in a normal fashion. But because the PCSK9 is present, it acts almost like a superglue. And instead of letting the LDL receptor go back to the surface, it stays with the LDL and gets transferred to the lysosome and gets degraded. So now you're destroying your LDL receptors. So the way to think about it is if you have too much PCSK9, the surface of your liver cell looks like the surface of the moon. You don't have a lot of LDL receptors, and so your LDL goes way up in your blood. And if we give an antibody against PCSK9, the antibody clears the PCSK9 from the serum right away within a few hours. And now the LDL receptors can recycle again, and you get a much lower LDL. So that's how PCSK9 antibodies work. So we know that the currently available ones include evolocumab and alirocumab. The data is very similar in terms of effectiveness. You can now, the standard doses are 75 or 150 milligrams of alirocumab every 2 weeks, or 140 milligrams of evolocumab every 2 weeks subcutaneously. We now have, for both drugs, the ability to give it once a month. So there is a slow infusion device that gives 420 milligrams of the evolocumab over a few minutes that you can strap on your arm. And the alirocumab, you just have the patient give 3 injections. And they've looked at the outcomes in terms of LDL lowering, and they're very similar. I'm going to skip this case. So this is evolocumab every 2 weeks, and you can see on the every 2-week dose, you get roughly 50 to 60% LDL reduction. When you do the once a month, it's very similar, almost exactly the same as every 2 weeks. So that allows you to give the 420 milligram dose once a month. If your patient just says, I can't stand every 2 weeks, I want it once a month. But so far, I haven't had any patient tell me. And it looks like this is looking at patients that got LDLs down below 70, and then over a 52-week period. So over the long term, that doesn't seem like the benefit of this drug wears off. This is actually Odyssey trial, so it's with alirocumab. And it just shows you there's sustained reduction in LDL over 52 weeks. Now, you may know that there was another drug in production called bococizumab. The difference between that drug and the two that I just mentioned that are currently on the market was it wasn't a totally human antibody. It had some mouse portion of the antibody. All of these drugs are made by mice. The first two are made by mice that are transgenically modified, so they make totally human antibodies. The bococizumab was humanized, so part of it was human, part of it was not. And patients developed antibodies to the drug that actually neutralized the drug, so over time, the effectiveness of the drug wore off, so they took it off the market. When you look at the most common side effects, and again, both drugs are very similar, injection site reactions. Now, neurocognitive disorders you see are 0.2% here and 1.2% in placebo. You might wonder, what about having very low LDLs, and does that cause any calculation or neurocognitive issues? Well, they actually did a sub-study of that FOURIER trial, the outcomes trial, that they took the people that had LDLs below 25. There were many of them, a couple thousand of them. And they did a very, very strict neurocognitive testing on the patients, whether they were on placebo or on in this case, evolocumab. And they didn't see any difference in neurocognitive. So this was the best done study to see if very low LDL driven down by PCSK9 antibodies actually caused any neurocognitive disorders, and the answer is no. In general, you can tell patients that having a low cholesterol reduces your risk for dementia based on every observational trial that we've got. There have been sporadic cases of people taking statins that they say they have trouble with math, but it doesn't cause dementia. When you stop the statin, it goes away. In general, the causes of dementia are high cholesterol, high blood pressure, etc. and treating those risk factors reduces the risk of dementia. Okay, one brief comment is that PCSK9 antibodies, both evolocumab and alirocumab, have been shown to lower Lp(a), but they do it in a large population. It's not predictable. So I'm not recommending you use these drugs to lower Lp(a) in individual patients, because some patients it will go up, even though their LDL went down a lot. Some it won't change, and some it'll go down. So it isn't a predictable Lp(a) lowering drug, even though a lot's been made of this. And the reason is we don't know how Lp(a) is removed from the blood. Probably not by the LDL receptor. Statin myopathy, when you look at patients in the Gauss trial, which was using these drugs in people that could not tolerate high doses of statin due to muscle aches, had to take lower doses or lower doses plus ezetimibe, you still got what you'd expect, significant reduction in LDL when you added these drugs without any increase in myopathy. So again, the drugs are indicated in those patients that either can't tolerate adequate doses or have inadequate lowering on high doses. And the most common reason they can't tolerate adequate doses is muscle aches, as you all well know. Again, this is the Odyssey outcomes trial, which is still, we don't have the outcomes yet, but there is a study with alirocumab looking at cardiovascular outcomes that shows significant reduction in LDL cholesterol, but it's going to take probably another year to see what that data is. It should be presented at ACC next year. Now, I just want to talk to you about evolocumab and what prospective randomized data we have now, which was the FOURIER trial. So the FOURIER trial was just presented last month at ACC, and it was evolocumab versus high-dose statin alone plus placebo injections. So these are patients at high risk with cardiovascular disease, either on placebo plus their max dose statin or statin plus ezetimibe, versus patients that got active evolocumab on top of their statin. And as you can see, there was a 59% reduction in LDL. And that translated into a significant reduction in cardiovascular endpoints. So the primary endpoint was a combination of cardiovascular death, MI, stroke, hospitalization for unstable angina, or revascularization. And there was about a 15% relative risk reduction. And remember, this study only went out 2.5 to 3 years. So you notice how these curves separate? And in the first 12 months, wasn't as striking, about a 15% reduction. But in the second 12 months, there was a 33% reduction in cardiovascular events. If you just look at cardiovascular death, MI, and stroke, 9.9 versus 7.9. The number needed to treat was in the 60s. So the argument might be, is a 2-year trial. We're used to looking at 5-year trials. The curves continue to separate. We'll have to see at 4 or 5 years what reduction we get. There wasn't a reduction in death, probably because it was a short study and the overall death rate was relatively low. This looks very similar to our previous statin trials in terms of what we expected, and almost none of them showed significant reduction in all-cause mortality. So that's not a shock with FOURIER. It did show in patients with peripheral arterial disease and stroke also a reduction in cardiovascular events, not just coronary patients. But this is what I want to focus on, is the baseline LDLs. So look at, this is the group, the quartile with LDL less than 80 at baseline on statin therapy. And they still got a significant additional reduction in cardiovascular events on evolocumab versus placebo. And it didn't really matter where you started, LDL over 109 versus LDL in the 80 to 90 or 90 to 110 range. At all levels of LDL at baseline, you got additional benefit with the therapy. And that just boils down to, if a patient's at high risk, no matter where you start, they should get aggressive therapy. So how do we summarize all the guidelines? If a patient has coronary disease, even if they're LDL 70, put them on a good dose of LDL lowering therapy, moderate to high dose statin. And then if they're high risk, we recommend high dose statin, even though they're starting with relatively low numbers. But if they're starting with high numbers and you give them that high dose statin and their LDLs are still elevated, don't be happy with that. Add more. So that's Dr. Brown's guideline. You can fit that in your shirt pocket. Give enough. But when the numbers are low, start with high doses in the high-risk patients. And don't be worried about too low in LDL. And this just shows you the data looking at all the quartiles in FOURIER on placebo versus on treatment. And again, it has a linear, see, even with LDLs down to 20, there seems to be continued return on investment getting LDLs very low. And it falls along the similar curves that the cholesterol trialists have done in the past. And in fact, this is all the data from the cholesterol trialists evaluation of all statin trials that shows for every 1 millimole of reduction in LDL, how much reduction in events you get. And FOURIER data here was exactly the same as all the previous studies. So it wasn't something magical about the drug, it was the percent reduction in LDL. So what are the recommendations? And so we now have some outcome data, but the NLA had come up with this recommendation, and in patients with atherosclerotic disease, if the LDL is still over 100, despite good doses of statin or statin plus ezetimibe, or the non-HDL is over 130, consider adding a PCSK9 antibody. If the LDL is greater than 130 in FH patients where we want to see it, FH you always want to see LDL less than 100, consider adding additional therapy, or non-HDL over 160. And then you might look at highly selective patients where the LDL is not so high. For example, somebody whose LDL is 85 that's been in 3 times in the last 2 years with recurrent stents, right? They're not low enough. So even though their number is 85, most of us would want to see it lower if they continue to have events despite other risk factor modification. And that you would do on an individual basis. There are a lot of proposed treatment protocols. This is from the American Heart Association paper by Sam Gidding. And what I would guide you to in my last minute or two here is the 2016 ACC Expert Consensus document. Remember I told you about the angry old men at the NLA yelling and screaming and telling the ACC they didn't know what they were doing? Well, behind the scenes I had a little something to do with this, getting them together and reminding them the rule of how you influence people. Getting them out to dinner together. And at the end of the day, they came up with this consensus pathway on what to do with ezetimibe and PCSK9 antibodies. And what the conclusion was is the thresholds instead of guidelines. So what do they tell you? They tell you, address those higher risk patients. So this is the patients with ASCVD or people with familial hypercholesterolemia, even without atherosclerosis, because again, 20 times the risk. Or patients with diabetes, or patients without diabetes who have a 10-year risk of greater than 7.5. If that sounds familiar to you, these are the 4 statin benefit groups that were from the 2013 guidelines. And of course, you focus on lifestyle. You make sure they're taking their drugs. And then you sit down with the patient and you talk about what we should do next. And though this is an impossible slide to read, the bottom line is you try to get 50% reduction with a high-dose statin, which is still the principal therapy. And then, if the patient doesn't achieve adequate LDL lowering, you could consider ezetimibe, but if you need more than a 20% LDL lowering, then you could consider going right to a PCSK9 antibody. Or if you add ezetimibe and you don't get adequate LDL below the threshold, in this case of 70 or non-HDL of 100, then you could consider adding the addition of a PCSK9 inhibitor or adding one of those drugs and then stopping the ezetimibe. Those are all options. But now we have numbers reintroduced that we may consider, not targets, but thresholds, and everybody's comfortable with that. And this was written by both ACC but endorsed by the NLA, so it's a nice melding of both. And if you haven't read it, it's called The Expert Consensus Pathway for the Use of Non-Statins, published in the Journal of American College of Cardiology. And very good. Gives you license to do what you're probably already doing. So in conclusion, LDL remains a central factor in the development of atherosclerosis cardiovascular disease, which you all know. Patients with lifetime low LDL are at low risk. It's food for thought about whether we should be treating earlier. When I was young, we had our first statin drug. I'd actually been in practice for a few years when lovastatin came out. And for those of you who have been in practice for a while, you remember we had to do slit lamp eye exams every 6 months. We were worried about cancer of the liver with lovastatin. And the standard statement was every cell in the body needs cholesterol. And what's going to happen long term if we put people on these drugs and get their cholesterol really low? And what happens is you live longer. And the eye exams are unnecessary. And then we had all kinds of guidelines that made it, you had to, add up risk factors and be very careful not to use these expensive and potentially dangerous drugs unless patients were really at high risk. But the world's changed. You can get these drugs for $5 for 90 days now. And we know they're not high risk. Unless you're pre-diabetic and you're on the maximum dose of the most potent statins, there's really no significant side effects. So maybe we should be thinking about a broader population of treatment, maybe a little younger in age. And that's what the genetic studies suggest. Someone will have to do a 20-year trial to prove that. Low LDL can be associated with metabolic syndrome and increased ASCVD risk, which is why with the low HDL and high triglycerides, even in a patient whose LDL is not too scary, you have to use non-HDL as a better predictor of risk. So additional markers of LDL-related risk, such as non-HDL or ApoB or LDLP, they're a better predictive risk, particularly in the population of patients that has high triglycerides. And high-risk patients, still, we've got a lot of them that aren't adequately treated. We need to make sure that we're aggressive with these patients and we don't let them fall by the wayside. And in those people who can't tolerate statins, and I've got some whose teeth itch and their stools glow in the dark on statins, then, whatever you think, whether you think it's real or not, to the patient, it's real. So we have to come up with alternative therapies, and that's where having drugs like ezetimibe and having drugs like alirocumab and evolocumab to add to these patients is very, very helpful. And so these alternative LDL-lowering therapies may represent an additional option. And thank goodness the studies suggest that both of those types of therapies further reduce cardiovascular events. So inhibition with PCSK9 antibodies is very promising, maybe the most effective approach in reducing LDL with non-FH but markedly elevated LDLs, heterozygous familial hypercholesterolemia, on statins or diet alone that aren't adequately controlled as an add-on to existing therapy. They've been shown to significantly reduce Lp(a), though that's not predictable. Good news is there's a drug in development that predictably lowers Lp(a) 70%, and hopefully that'll show a reduction in cardiovascular events. That remains to be proven. In all these patients on PCSK9 antibodies with over 6,000 in clinical trials, we haven't seen any significant adverse effects, which is encouraging, except for very rare allergic reactions. And they have been shown to reduce atherosclerotic cardiovascular events when added to statins, particularly both look like it retrospectively, prospectively. Now we have a trial with evolocumab, and soon we'll have an alirocumab outcome trial. So with that, I'm going to stop. Maybe we have a couple minutes for questions, and I would ask you to please complete the post-survey so you can get your CE credits. And thank you for your attention. Yes?
Yeah. Do you have a preference of one statin over another in your practice? I mean,
Not really. I think, I rarely use simvastatin anymore, primarily because there's so many drug interactions. And I can't control if a patient, maybe they develop hypertension and one of their physicians puts them on a calcium channel blocker that could cause them a higher likelihood of myositis, for example, or they get put on amiodarone for AFib or whatever. So the statins with so many drug reactions I avoid. I don't use a lot of pravastatin or lovastatin anymore because of the potency issues. However, in those patients that can't tolerate atorva or rosuvastatin, I will go back and use prava, fluvastatin, lovastatin, and use the highest doses plus ezetimibe because I want those patients to be on a statin if possible.
and is there still some suggestion that some of the benefit of statins may be an anti-inflammatory effect? I thought
That's
I
a
remember
really
reading
good question.
something. Yeah.
So it turns out there's no doubt that you can show that all the statins reduce inflammation in a test tube and in vitro models. They improve blood viscosity. There's a lot of things they do. They improve endothelial function. But what you can't show is that the reduction in risk that you predict by the change in their lipid profile when you put them on a statin isn't as predictive as anything in what the outcome is going to be. In other words, you get exactly what you would expect when you look at the entire lipid profile. So even though there are these so-called pleiotropic other effects, you can explain all the reduction in events from the changes in their lipid profile. Not from the LDL alone, but from ApoB or non-HDL, because remember, statins raise HDL and lower triglycerides also. So if you look at non-HDL reduction versus reduction with anything else, including diet, you get exactly the same reduction in risk with a statin or other methods of lowering cholesterol. So we're all excited about those effects, but it doesn't translate any more than the lipid profile changes into event reduction, if that makes sense. With one exception, there's less angina early on if you give a statin versus not. And the Miracle trial was one where they gave high-dose atorva right after an acute event for 6 months versus placebo, and there were fewer readmissions for angina. But the outcome benefit in terms of heart attacks, angioplasty, hard cardiac endpoints takes anywhere from a year to 18 months to see a difference compared to placebo.
Yeah,
Yes, sir.
Should all these patients over 75 be in all these statins?
Yeah, it turns out that we've got data in lots of patients over 75 that they get a similar reduction in cardiovascular events over a 5-year period. And they don't seem to have any significant increase in side effects. So if you see a patient who's 80, in my opinion, and this is my opinion, who looks like they're going to live to be 90, the age is the single biggest risk factor for a cardiovascular event, right? So they're going to be at the highest risk for an event. And we've got data that you can cut their risk in half. Why wouldn't you give it to them? On the other hand, if somebody's in a nursing home with Alzheimer's and severe rheumatoid arthritis, you're not going to give them a statin or many other things, right? So I think you have to be a doctor on top of everything, or a healthcare provider. You got to be someone who can assess a patient and decide what's best for that individual. But age by itself should not be a reason not to treat somebody with a statin.
And then one other quick, what's the role of high HDL in your consideration?
Well, it depends. So if a patient has atherosclerosis already, high HDL, I forgot about it. I don't even look at it. If they've already got any evidence of atherosclerosis, carotid, abdominal aorta, peripheral vascular disease, coronaries, I'm going to treat them like every other patient, get their LDL aggressively lowered. But in primary prevention, where they don't have anything else, what we traditionally do is think of a high HDL as suggesting that patient may be at lower risk. So if someone has no other risk factors, their HDL is high, what the old recommendations was to subtract a risk factor. So let's say you were hypertension and you had a family history where your LDL target would be 130. Now you could just remove one risk factor and that would bump your LDL target up to 160. I think that's not unreasonable, but in today's modern era in 2017, if I am not sure, I get a calcium score. And I see if the HDL is high and their LDL is borderline, or they got a family history, or is that HDL protecting you or isn't it? If the calcium score is 0, I'm pretty comfortable treating that patient conservatively. But if the calcium score is elevated, I forget the HDL and I treat. So we do calcium scores for $49 at my institution. And, it's very little radiation. It's a lot cheaper than a regular stress test, which is often a useless test. So I find that to be very helpful in stratifying what to do in those borderline cases. Well, thank you very much for your attention.